Maverick Physical Therapy. Little condensed and broken down episode of TZ1A to TZ1B to TZ1C of pitching mechanics. In the specific TZ1A episodes, B and C episodes, we generally speaking went through things, how to assess, kind of how to treat. We talked about the biomechanics of things a little bit. In these condensed episodes, we will be kind of focusing on a few articulations and what's happening from the bottom up and the top down, and how that's affecting the motion, real and relative motion that we're getting. So let's in this episode focus on the hips and what takes place from TZ1A to TZ1B and then C and why. So review TZ1A. Let's start from the wind up or the slide step position. So we're set, and we've talked a lot about how, again, top down driver, the upper extremity will load the hip, and that's exactly what we're talking about when we're looking first at TZ1A in terms of getting the hands preset, or at least moving in a position in which we're loading the back shoulder and the back hip, focusing on the hip. So upper extremity wise, you'll oftentimes see a lot of individuals, let's say a right-handed pitcher, break the hands at midline or ahead of midline. And we don't want to do that because we neglect the opportunity and the power of what we can do to load the cannon, load the rubber band in the hip and the back scapulothoracic joint. So TZ1A right here, whether you start at midline or beyond, we need to get to that point so that we can load the right hip into internal rotation. So what happens there, hip-wise, if this is my right femur, which it is, and my pelvis, the pelvis here is going to be, and the femur are going to be rotating to the right. But the pelvis is going to be rotating to the right faster and further than what the femur is, really loading up this posterior hip capsule and this posterior pelvic girdle right here. And so the upper extremity has a great deal and a great part in doing that, as from the top down it's going to take that scapulothoracic joint and the thoracic spine, swing it to the right and load it on up, give us that great kind of top down load as it's initiated from the left lower extremity as well. So that has an effect on what's taking place then on the right ilium and the right lumbo-pelvic kind of junction, lumbosacral junction, and that hip there. So we have this shooting across this top down load of the upper extremity, but then of the opposite hip and lower extremity, the lead side hip, to the back side hip in internal rotation. So as we then transition to TZ1B, let's put this down, and the ground's pretty hot today, so you might see me jumping around and dancing. So as we transition to TZ1, from TZ1A to TZ1B here, hip-wise, what takes place here, we obviously are, depending on the individual, we develop a lot of internal rotation right there. In position and motion-wise, what's taking place as we go into TZ1B? The big emphasis is as we go into TZ1B, we're getting hip extension. We're getting a lot of hip extension, but then abduction of that hip. So the pelvis will laterally rotate, or externally rotate, or rotate left, I should say, rather. But because we have this top-down load taking place as well with the upper extremity, and this bottom-up load of the foot and the ankle unwinding from the ground, we will get this initially. So from TZ1A to B, we'll have this medial rotation of the tibia and of the fibula taking place, which is going to be faster than the femur rotating towards home plate, which is going to be faster than the pelvis rotating to home plate, which gives us relative internal rotation at that right hip. So when I jump in and start doing my FMR techniques on an individual that's very limited in TZ1B and C, based on my assessments, some things that I will initially see that that are problematic for an individual mechanically is that if we're not able to load that posterior pelvic girdle, that posterior hip joint capsule, take advantage of the three-dimensional qualities of the butt complex, we're going to bail out of that and into external rotation early. We'll bail out of that into external rotation early, and depending on what's taking place, thoracic spine, scapulo-thoracic joint, if we're not able to take advantage of this continual kind of this distal loading and mobility principle and this proximal stability and acceleration to load those proprioceptors, we'll bail out early and we won't be able to have that good extension and abduction, taking advantage of that inferior hip joint and that medial hip joint capsule as well. So, review-wise, so TZ1A to TZ1B right here. And again, although things are rotating to the left towards home plate, as I'm a right-handed pitcher mimicking in this position, things are rotating faster than others here. So we'll go from in TZ1A, foot and ankle, we're starting to get some inversion even though we're everted. And we'll transition to some eversion, and then we'll get some inversion, which is going to enable this kind of this medial rotation load taking place, which is going to give us this internal rotation at the right hip. Show you a breakdown down right here. So as we start to head towards home plate, we're going to get abduction and we're going to get some extension as the femur starts to travel towards home plate faster than what the pelvis does. And in just a second, I'm going to show you why. It's a big transformation as we transition to TZ1C. I'll tell you why we do that and then why we should not neglect TZ1B and TZ1C as often is. So TZ1A, TZ1B, TZ1C. So A, B, and then C. We start to unleash ourselves towards home plate. What happens then in TZ1C is that hip-wise, now we're going from this abducted, this extended position, this internally rotated position, this econcentric like coupling of the gluteal complex, to now we've taken advantage of moving and unloading in a plane so that we can take advantage of that rotational plane. Take advantage of the rotational plane, load the cannon more. So now that we rotated and loaded internal rotation, we can explode external rotation. So we then get this separation of the femur and the pelvis. It would be like you passing a vehicle on the highway going 80, they're going 70. You look in your rear view mirror, you've got kids in the car, whether they're yours or your cousins or whatever they are. They say, hey, that car's going in reverse. It's not. You're going in the same direction to the same place. One's just going faster than another. So the pelvis then in TZ1C rotates towards home plate faster than what the femur does because we just exploded out of that internal rotation right there. So now we have external rotation of the right hip, and those are all things that we need to be able to assess and take a look at with regards to these transformational zones. Transformational zones, again, are areas that we assess / evaluate and areas that we treat in and provide performance enhancing techniques to go after, because that's where injuries occur. If we do not load properly, we will not be able to unload. End result, if we have inconsistency, inefficiency, accumulation of chronic fatigue, pain, and wear and tear, a variety of stages of tendinopathies, whether it's in the shoulder, the elbow, capsular related patterns in the shoulder, we need to look elsewhere throughout the body. It starts from the ground up, and it's all about the chain reaction and these closed kinetic chain-like principles of multi-joint compression congruency and approximation to load to form dynamic stabilization, to explode through that, and as we explode, to further load other segments top down and bottom up from that. That's what happens TZ1A to TZ1B to TZ1C. That's why you should look back at the previous videos that we detailed on these to take a look at what we did to kind of assess and kind of to treat a little bit in regards to the hip. What I find to work well again is getting the dowel on out for TZ1B and C, doing a lot of progressive oscillations. I love using the super bands as ways to anchor superior up to the proximal femur and then also distal in these positions to really open up the hip joint capsule. So a review of that would be if I wanted to go after TZ1B and a little TZ1C, and again, assessment and treatment right here. I'll go kind of from the back side here so you can kind of take a look at that instead of straight on you, just an angle on that right now. If I want to go like a TZ1B here, I could just kind of preset and use that tubing as a way to really open up the inferior and that medial hip joint capsule. I could go further distal, just superior and medial to the knee. And I can really feel a pretty good load right on that inferior and that medial hip joint capsule. I'll use my dowels for that as well. The lunge matrices, the lawnmowers, the pick and the press, the lunges. I love to sequence the load and unload the hips with those. Play around with those. Episode 2 coming on up. Thoracic spine, scapulothoracic